Move on to our next speaker, and it's my pleasure to introduce Irena Stefanoova, who is a trainee. She is currently in Liverpool, and she's taking some time out of training for research into biomarkers for early detection of PDAC, which is amazing.
Thank you for the opportunity to present the UK experience on robotic common bile duct exploration. My slides are showing data from these 4 centres in the UK. And when it comes to CBD stones management, there is still lack of consensus on the gold standard approach. So the NICE guidelines state that patients with symptomatic and asymptomatic CBD stones should be offered bile duct clearance and laparoscopic cholecystectomy, with the option to CBD clearance to be undertaken either endoscopically or surgically. UK practice largely varies in this, and it's influenced by local availability of ERCP services, but also surgical expertise in bile duct exploration. And my talk does follow up on Mr. Bhatti's talk as well in terms of CBD exploration. ERCP is often limited and challenged by multiple hospital admissions, repeat procedures, and limitations in the management of very large duct stones or difficult stones. Whilst laparoscopic CBD clearance when performed via the transcystic approach is challenged by stone size and also by anatomy of the cystic duct. If it's performed by the transcholedochal approach, the concerns that most surgeons have is the associated risk of bile leak. The recent advances of minimally invasive approaches and the integration of robotic surgery in CBD exploration could potentially bridge these challenges and essentially increase the uptake of surgical bile duct exploration. So to assess the outcomes of robotic common bile duct exploration in the UK, we undertook a retrospective multi-center cohort study. 4 hepatobiliary centers in the UK contributed data, and we included all consecutive patients who underwent robotic bile duct exploration between 2019 and 2024. Only 1 center had exclusion criteria, and these were concurrent cholangitis, Parkland grade 4 cholecystitis, or moderate or severe pancreatitis. The procedure types were elective or emergencies, and CBD exploration was undertaken either together with robotic cholecystectomy or alone following a previous laparoscopic cholecystectomy. The primary outcomes were stone clearance confirmed on cholangioscopy, and secondary outcomes were conversion to open procedure, post-operative complications and intervention, length of stay, readmission rates, and mortality rates. Our results demonstrated that the centers performed a total of 102 robotic bile duct explorations in the time period. The majority of patients were female with median BMI of 28. Most patients had ASA grades either 2 or 3. 26.4% of patients had previously either performed successfully or attempted laparoscopic cholecystectomy, and 16% also had a previous upper GI procedure such as Roux-en-Y gastric bypass or gastrectomy or sleeve. Some of our preoperative data here, so that most procedures were actually elective, but we did have 18.6% of cases performed as acute. Main indications were just isolated CBD stones. However, some of the patients did have Miriti type 1 or type 2, concurrent cholangitis, or retained bile duct stent. About 50% of patients had previous hospital admission with cholangitis, and around 60% had preoperative biliary drainage. The most commonly undertaken method of biliary decompression were endoscopic. And in terms of numbers of ERCP attempts, 58% had 1 attempt, whilst 27% had 2 ERCPs prior to robotic surgery. With regards of biliary stents in situ at the time of robotic procedure, we found that 1/3 of patients still had their stent. Procedure types is what this slide is demonstrating, and we decided to break down the procedures to assess the rate of conversion to open because we had quite a lot of heterogeneity. You can see here that when bile duct exploration was performed together with robotic cholecystectomy, the conversion rate was minimal. It was only 1.4%. But when it was undertaken after previous cholecystectomy, this rate rose to 30.4%. The overall conversion rate was 9.8%. Next, a few of the procedure details. So the median operative time was 153 minutes. The most frequent way of accessing the biliary tree was transcholecystectomy approach in 86% of the cases. And the cholecystectomy closure was most commonly undertaken using 4-row PDS continuous suture. 76% of patients had intra-abdominal drain placed, and 15% had an antegrade biliary stent as well during the procedure. Success in stone clearance was reported in 92% of the cases. Here we report our complications. So the overall morbidity rate was 19.6%, with complications clavia and Jindo 3B and above of 4.9%. We had a bile leak rate of 2.9%. 4 patients did require a return back to theatre, and this was either for washout of a collection or an abscess or for port side complications. In terms of post-operative interventions, we had 2% of interventional radiology drainages, and 8.8% of patients underwent post-operative ERCP for either retained stones, one of them for bile leak and one of them for common hepatic duct stricture. The median length of stay was 2 days, and 30-day readmission rate was 4.9%. We looked at 90-day mortality rate as well, which was 2%. One of the patients died of multi-organ failure from pancreatitis, and then the other one developed pneumonia, but this was 30 days after their discharge from hospital. Our data highlights that robotic bile duct exploration is safe and effective. It's associated with high stone clearance rate and low bile leak rate. We do acknowledge the limitations of our study and its retrospective nature, intercenter variability. A longer follow-up would be valuable to better assess the rate of CBD strictures, given the fact that transcholecystectomy approach was the most frequent access to the biliary tree. And then next, I wanted to show you also a video, a case that we undertook at the Royal Surrey Hospital of a 37-year-old lady who had background of EDS, got previous laparoscopic subtotal cholecystectomy with a stapled Hartmann's pouch through the Hartmann's pouch. She was referred to us as a tertiary center with recurrent symptoms from stones in a small remnant, and had an ERCP after the laparoscopic procedure that did demonstrate that there was no duct stones at the time. She was also referred for spyglass. However, due to MRCP findings of a tortuous duct, this was deemed unlikely to be successful. Hence, a decision to perform a completion cholecystectomy and bile duct exploration was made. This is the video. So first, we take down the adhesions of the liver to be able to access and identify the gallbladder remnant. Not sure why it's not playing. Don't worry, let's go with the next slide. It was an interesting video because the common bile duct exploration is performed by Mr. Penkeru, who is here in the audience, and it's absolutely perfect. Just one attempt of retrieving the stone, completely successful. Our next project here is robotic completion cholecystectomy. So we have currently 3 hospitals that have already contributed data. And I want to show you a few preliminary results, but sorry about the technological issues. So far, we have 44 patients. 72% of these have had previous subtotal cholecystectomy, and 27% an abandoned elsewhere that was referred to us as tertiary centers. So far, we've had only 1 conversion to open procedure, and 1 patient with post-op collection and 1 patient with retained CBD stone. We're looking forward to analyzing the rest of the data and sharing this with you very soon. So if anyone has completion cholecystectomy done robotically, we're happy to collaborate. And my final slide was actually an acknowledgement slide, and I want to say thank you to all the collaborators for these studies that we've done, and just welcome any questions. Thank you.